There are four types of multiple sclerosis based on the patterns of symptoms over time. And to break this down, we can use this graph on the right. Um, and then basically, this is the y-axis represents the increasing disability, and the x-axis is basically the time as the lifespan of an individual. So at first we can go through the relapsing remitting multiple sclerosis, which is basically a condition where there is bouts of autoimmune attacks happening over months or even years apart, and then these cause an increase in the level of disability. So as we can see in the graph, it's not very consistent. It kind of like there are symptoms in various periods of time. And then this are unfortunately though has it's the most common type of condition in the multiple sclerosis subtypes, and the remyelination process is not complete, so there is often some residual disability that remains, and with each attack more and more of the central nervous system gets irreversibly damaged. In the RRMS, it's also typically no increase in disability between bouts. As we can see again, there are gaps. So the line stays kind of flat during that time. And the second type is called the secondary progressive multiple sclerosis, or in short, SPMS, which is this one. And looking into the graph, we can see that it becomes kind of pretty it is kind of initially pretty similar to the RRMS, but over time the immune attacks become constant, which is a steady progress. So initially it's kind of like similar to the RRMS and slowly it just becomes consistent. And the third type is the primary progressive multiple sclerosis, PPMS, which is basically one constant attack on myelin, which causes a steady progression of sorry, it's this one, the steady progression of disability over a person's lifetime. And then the final one is the progressive relapsing, or in short, our PRMS. And this is very constant attack, but this time the bouts are superimposed, and during which the disability increases even faster, and it's just constant increase. So yeah. And speaking of treatments, there are three categories. First is the acute relapse management. This kind of focuses on the neurological symptoms, and it kind of intervenes and improves the patient outcomes by focusing on the neurological symptoms. And then there is also disease modifying treatments, in short DMTS, which is basically the use of MRI and lab tests to confirm relapses and then kind of rule out the other conditions that might be needed for um, like accurate treatment. And then lastly is symptomatic treatment, which kind of incorporates multidisciplinary care to kind of support emotionally and socially of the individuals living with multiple sclerosis. Here are some drugs or medications treatments listed, such as the disease modifying therapies, DMTS. These include ocrelizumab, which kind of targets the immune cells. Neuroprotective protective agents focus on neurodegeneration. The remyelination drugs could include OPCNumab, and it kind of it's still being studied on, and combination therapies can be used to treat progressive multiple sclerosis and kind of focus on inflammation as well as remyelination. And these are a few drugs as well, like high dose biotin. It kind of boosts the mitochondrial energy, and the other two types as listed over here. And this image kind of summarizes all the drugs, a few drugs that works on few aspects of the CNS, and these are the drugs that work on the periphery nervous system. And then we can see that there is LM2-ZAB, there is delphamidopridine, which kind of works on the sodium potassium channels. There is also neuroprotection, kind of works on mitochondrial abnormalities, and also ocrelizumab and natalizumab works on the blood-brain barrier, allowing different molecules to be passed and to be regulated through the blood-brain barrier. In this image here, we can see there are different categories that treatments could be focused on, such as the mitochondrial protective strategies, which means targets are basically oxidative stress and mitochondrial dysfunction in neurons. And then there is also strategies targeting B and T lymphocytes. In this category, the goal is to suppress autoimmune attack on myelin so that basically demyelination doesn't occur. There is also anti-inflammatory strategies, which kind of targets glial cells to be activated and exotoxicity. There is lastly the remyelination strategies, which kind of has a goal to repair damaged myelin sheaths, which kind of focuses on remyelination again. This slide displays the toxicity as well as the efficacy of the drugs from these different um, year ranges, and bigger the circle is, the higher the efficacy, as well as the darker the circle is, higher toxicity these drugs have. As we can see, natalizumab as well as this drug over here has higher toxicity as well as higher efficacy. In terms of ethical considerations, there needs to be informed consent and autonomy. So, multiple sclerosis patients are mostly challenged in terms of their cognitive. So, that means they are not able to provide consent to the medical representatives, doctors, and nurses. This means there must be a use of surrogate decision-making roles, such as a caregiver might be giving a decision role, but this kind of breaches the autonomy of the patient themselves. And this kind of both collectively is kind of like a legal framework variability. Some hospitals kind of focus on the surrogate, some focus on the patient, and it kind of challenges the um, consent and autonomy of the patients and the caregiver. And then a little bit look into the caregiver burden and resource allocation is firstly, the caregivers might suffer from physical burden, such as kind of they might develop risk of musculoskeletal injuries from lifting or assisting the patient. There's also emotional and psychological burden, as the caregiver might feel burned out emotionally or physically, and then there is also the financial strain that may be faced by the caregiver, such as death, reduced quality of life. And then there is also social and relationship challenges, as the caregiver might feel lonely and is kind of like um, uh, kind of distant from the outside world while taking care of the multiple sclerosis patient. And to kind of help that, the resources can be allocated to few categories as mentioned over here, such as like neurologists or MS clinics are mostly unevenly distributed across like towns, cities, like urban or rural areas. There is also rehabilitation services that might be needed, and it kind of has to be sufficient physical and occupational therapy access for the patients. And I think pharmaceutical assistance might be help to the patients as well. And this could be achieved by free or discounted drugs for these patients. And then over here summarizes this flowchart summarizes all the categories, all the sections that we have covered so far. Firstly, what multiple sclerosis is, it's basically demyelinating disease that affects CNS. And then the immune response and damage is basically on based on the blood-brain barrier, and as well as T cell activation. And then there is also different types of multiple sclerosis. We discussed four different types and they're kind of how they're differentiated. And then talking about the symptoms of multiple sclerosis, as well as the diagnosis and treatment of multiple sclerosis. And this includes the drugs, as well as imaging techniques needed to diagnose. And focusing a little bit on the future directions, there needs to be enough research or on therapy, technology, as well as patient-centered care, and that would aim to improve the quality of life as well as disease management for these patients. We can kind of focus on stem cell therapy such as HSCT, which is the hematopoietic stem cell transplant. This means the immune system would reboot for aggressive RRMS type, as well as there is MSC, which is mesenchymal stem cells, and this could potentially protect the neurons and repair them after demyelination. There also needs to be biomarker guided treatment, such as the personalized DMTS. This could be tailored to the patients and based on the disease subtype. Right now, there is no cure for multiple sclerosis, but most of the um, most of the drugs and therapeutics kind of focus on the relapsing remittent multiple sclerosis type, in short, the RRMS. So there needs to be more studies done and drugs developed uh, focusing on the other subtypes. And what I think would be also interesting to look at is AI powered monitoring, such as that could kind of predict the relapses using EHR data, such as IBM Watson used previously. As this is not a live presentation, I am guessing there might be some common questions. So these are few listed over here. First is, can diet or exercise help multiple sclerosis patients? And the answer is yes. Diet definitely does, as anti-inflammatory diet would reduce inflammation in the neurons and in the central nervous system, and these include Mediterranean or low processed foods. And multiple sclerosis patients can also exercise more, which would improve their strength, balance, as well as their mood. And incorporating vitamin D may also reduce relapse risk, but consultation from the doctor is required. And second question is, why do multiple sclerosis symptoms fluctuate? This is due to the relapses as new inflammation causes acute worsening. There is also pseudo relapses that includes temporary symptom due to heat, stress, or infection. And there is also progression as gradual nerve damage causes permanent changes. And lastly, can pregnancy affect multiple sclerosis? Answer is yes. Pregnancy often stabilizes multiple sclerosis as the hormones kind of suppress the immunity. That doesn't mean necessarily people should go around getting pregnant. And there is also higher relapse risk after giving birth, postpartum, especially after 3 to 6 months after delivery. And most DMTs must be paused before conception, as it might affect the fetus, and breastfeeding also may have protective effects on multiple sclerosis. This concludes this presentation, and I would like to send out some acknowledgements, and these are the following are the references I used. Thank you.